welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is thalassemia. Now, to give us an in-depth knowledge about this particular disorder, we have with us today Dr. Anupam Sachdeva, who's the chairperson, Department of Pediatrics at Sir Gangaram Hospital, Delhi, with his chief interest being pediatric hematology. So, welcome to Medical Dialogue, sir. It's really a pleasure to be interviewing you here today.
Thank you very much, Nandita. Pleasure being with you all.
Great. So, sir, basically, we're talking about rare diseases and we're talking about thalassemia. If I club both together, if you could just explain to us what is thalassemia and is it considered a rare disorder? And also, if you can highlight on how does it differ from other types of anemia?
Well, thalassemia is an inherited red blood cell disorder. So it is inherited and it has a genetic this thing. So what happens is that if you have a mother or a father who's got thalassemia trait or what we call as a carrier status, then both of them, if they are traits or carriers, they can pass on the disease to their children in 25% chances in each pregnancy, 50% chances of having a trait in each pregnancy, and 25% having a normal child. Now, thalassemia is different from other anemias because it is, as I said, it is an inherited disorder. And if you can identify the carriers, which is the people who are carrying the gene for that, then we can prevent the disease also. And the other issue is that in thalassemia, the anemia does not respond to any hematinics. In fact, a lot of the situations, we don't give any hematinics in these cases. The only way to treat it is to give blood transfusion, which means pack red cells which are leukodepleted, and then take care of the patients. Now, with each new unit of packed cell which we give, red cells, we are putting in a lot of iron in the form of hemoglobin. The body does not have the ability to handle this iron, and we have to take it out with the help of medication, and that requires either tablets or injections for a whole lifetime. If this iron is retained in the body, it goes and damages the liver, the heart, the endocrines, especially growth of the child and sexual development of the child. It leads to formation of bones which are not very strong, and it can lead to fractures, etc. So from a single disease, it becomes a multi-disorder condition. So that's what thalassemia is.
Great. That was a crisp explanation, sir, of what thalassemia is, why it is considered to be a rare one. Now, if you could just also give us a little detail on it, if we're talking about the different types of thalassemia, what are the different types and how do their symptoms and also their severity vary according to each type?
Okay. Now, if we are looking at thalassemia as a whole, then we categorize it as hemoglobinopathies in a nutshell. The various hemoglobinopathies which are there can be beta thalassemia, in which the formation of beta globin chains is massively curtailed. And then there is alpha thalassemia, in which the chains of the alpha globin chain are also curtailed. Then there can be point mutations, like in sickle cell anemia, where there is substitution of one amino acid by another one, which leads to damage to the red blood cells. Then, of course, there are other types of thalassemia, which is HBE, HBD, Punjab, etc. Now, in our country, about 3.9 to 4% of the population of India is a carrier for beta thalassemia gene. The incidence of beta thalassemia is more common in Punjabis Gujaratis, Lohanas, Banuchalis. So you can have affected areas are Punjab, Haryana, Gujarat, Maharashtra, Western UP, and a lot of these northern states. Uh, then there is sickle cell anemia, which affects the population primarily in the tribal areas, that is Jharkhand, Chhattisgarh, parts of Madhya Pradesh, Odisha, Maharashtra, Gujarat, and a specific part of Tamil Nadu, which is Nilgiri Hills. So you have this kind of the HBE is affecting primarily people from Odisha and West Bengal, Assam, etc. So you can have either these pure conditions, or you can have even interaction between various types of thalassemia. For example, you can have HBE beta thalassemia. You can have HBS, which is sickle with beta thalassemia, and you have your signs and symptoms based on those, uh, you know, permutations and combinations. So that is what thalassemia is in a nutshell. The incidence of sickle cell is ranging from 2 to 35% in some populations in our country. And over a period of time, we have found that nearly 10,000 new thalassemics are born every year.
So now you gave us a brief about the different types of thalassemia. Why is it considered a rare? Its symptoms, as well as you mentioned about the different types and permutation and combinations that can occur in. So if a layman if a physician probably has to diagnose it, what are the parameters that one has to look into, and what tests are typically conducted to actually confirm the condition?
Well, beta thalassemia usually presents by 5 to 6 months of age. That is because the HbF in the body of the child goes down by 5 to 6 months, and it is replaced by HbA, or the adult hemoglobin. Now, the body does not have the ability to form HbA or adult hemoglobin. So as the HbF levels come down, the HbA is not able to go up, and that leads to anemia. Now, what are the signs and symptoms of a child with thalassemia? The child will be lethargic, pallor will be there. The child will not be very happy child, will be an irritable child, and the child will also have sweating around the head when he's drinking milk, whether it is breastfeed or it is uh, any other feed. So these are some. And when you look at the abdomen, usually the spleen is enlarged and the liver is enlarged. So these are the initial signs and symptoms. If the child is not treated and not diagnosed, then the child can go into failure also later on in life at 1.5 or 1.5 years of age. Now, how do you diagnose it? First of all, you confirm that the child has anemia. Number two, then you can look at the CBC. CBC will show lot of will show anemia, will show microcytosis, hypochromia, and will also show lot of anisocytosis. The RDW, which is red cell distribution width, will be increased. And to confirm it, you do a test which is known as either electrophoresis or high performance liquid chromatography, which will tell you what is the amount of HbF, A2, etc. in the body. HPLC is one test which can help you in making a diagnosis in HBE. It can make a diagnosis of hemoglobin, sickle cell also, and other kinds of anemias also. Unfortunately, alpha thalassemia is not picked up by the HPLC very clearly. So what we do is Once we have the HTLC, we make a diagnosis of beta thalassemia major, and then we can go in for mutation analysis, which will tell us what are the mutations which are affected in the family. Now the question is, why do we need a mutation analysis? It is very important because we have to come to know what is the type of mutations which occur in our country. Number two, when the patient parents go in for the next pregnancy, if we know the mutations, then we can look for those mutations in the proband or in the fetus at 10 to 12 weeks of age and make a diagnosis. Whether the child is suffering from beta thalassemia major, is a trait or a normal. If he's got beta thalassemia major, we go ahead and abort the child. If it is straight and normal, the pregnancy continues as usual. So these are the ways to make a diagnosis of beta thalassemia major.
Great. You explained well, sir, the stepwise procedure of coming to the diagnosis. As you mentioned, first CBC and then you proceed with further tests. Now, if once a physician diagnoses a thalassemic patient, so what are the treatment options that are available, and what do you think is the choice? How will you decide on what choice of treatment to be given to each patient?
First thing is that we must cure the anemia. And the only way to cure the anemia is to give what we call as ideally packed red blood cells, which are leukodepleted, NAT tested for HIV, HBsAg, and HCV. Now, with this, the patient gets in a lot of iron, as I said before, and we have to take care of the iron at around 2 years of age or so. And then it goes on for a lifetime. Now, this is the routine or treatment which is given for thalassemia. Now, if you have a matched sibling donor, then we can go in for what we call as bone marrow transplant or a cell transplant, stem cell transplant. Now, this is a expensive procedure. But when you look at it from the point of view of that it was a cure for thalassemia, then it is not that expensive, because to maintain a thalassemia child, per year you spend about 2 lakh rupees. And the transplant costs between 10 to 12 lakh rupees. So over a period of 5 or 6 years, you are actually spending about 10 to 12 lakhs. And this transplant will give the cure to the patient, and the patient will not need treatment after 1.5 years old.
Great. Now, sir, if I may ask about the next aspect about transfusions. So, if you could just discuss the role of blood transfusions in managing thalassemia in children, as well as what are the potential risks as well as its benefits.
As in other cases also, blood transfusion carries with it the inherent risk of transfusion transmitted infections. We look for those transfusion transmitted infections before the transfusion is given. There are 2 methods to look for it. One is with the help of an ELISA, and the other is with the what we call as nucleic acid testing. What we do with these nucleic acid testing, which is the best way of looking at the transfusion transmitted infections, is that reduce the window period for the disease drastically. That is why we are recommending that as far as possible, every child should get nucleic acid tested blood transfusion. So then, of course, there is a risk of reactions, blood reactions, which may be in the form of a hemolytic blood transfusion reaction. Number 2, it can be in the form as what we call as NHFTR, which is non-hemolytic febrile transfusion reaction, which is very common in those who are multi-transfused. And these patients, usually by 8 or 9 transfusions, you start getting what we call as NHFTR. One of the ways to prevent the NHFTR is to give leukodepleted product. And the best way to leukodeplete these products is to not do bedside leukodepletion, but do leukodepletion in the blood bank. That reduces the chances of NHFPR drastically. The third thing which you can get is known as alloimmunization. Alloimmunization is that when you are giving multiple transfusions, the body reacts to the various antigens on the surface of the RBC. As we know, RBCs carry what we call as ABO blood grouping, RH blood grouping, but there are a lot many more blood groups like Cal, Duffy, etc., which are there. We test only for ABO and RH, but in this patient, you can have reactions to Cal, Duffy, etc. also. So what we recommend is that at the initial stage, when the patient comes to us, we should do a extended blood grouping where we know the ABO, RH, Cal, Duffy, etc. all of them. So if your patient gets into alloimmunization, you can look at these multiple blood groups and give them a matched blood to all these blood groups.
So lastly, sir, if you could just give us insights into any ongoing research efforts or any clinical trials that are aimed at improving the diagnosis as well as the treatment aspect of thalassemia.
Ma'am, what we have to do is, if you look at the making diagnosis of thalassemia, the best way is to go, as I said to you, from the CBC, peripheral smear, HPLC to mutation analysis. Then coming to research, there is a lot of research going on how to improve the results of transfusion, bone marrow transplantation. Now, in the mid 80s or 90s, the success rate of bone marrow transplant was in the range of 65 to 70%. But with changes in the and understanding in the pathology of the disease, we have now increased it to now almost 90 to 95% success rate. Of course, there is a lot of morbidity involved. A lot of problems can be there. The patient stays in the hospital for anywhere from 21 to 30 days or even more. But then that is an impact. Number two, there is a lot of effort going on to do gene therapy in these patients, and it has met with some success. The success is more in the sickle cell than in thalassemia, because sickle cell is a point mutation, whereas thalassemia is not a point mutation. But generally speaking, in our country also, there are 4-5 groups which are moving towards gene therapy in our this thing, and to make it more. Unfortunately, gene therapy is very expensive, and it may run into a few crores. But with the indigenous gene therapy, will bring it down to drastically to less than even 1 crore. So we are moving in the right direction. I hope in the next 3 or 4 years, we shall start clinical trials on gene therapy in thalassemia as well as sickle cell.
Great. So thank you so much, Dr. Anupam, for joining us today
Thank
at
you,
Medical
ma'am.
Dialogues. It was lovely to be interviewing you here today.
Thank you.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.